Welcome to the deep dive. Today, we're tackling a really common frustration. It's that feeling, that guessing game, when trying to figure out if someone's truly ready to get back to sport after a foot or ankle injury. It affects everyone: athletes, weekend warriors, clinicians. And for way too long, it's felt, well, pretty subjective, hasn't it?
It really has. Too much guesswork, not enough solid data.
Exactly. But our source material today is all about changing that. It's based on this really impressive online course designed to bring clarity. An evidence-based algorithm, actually. It feels like a potential game changer for lower body rehab. And to help us unpack it, we've got an expert guide. We're joined by a doctor of physical therapy, board certified in orthopedics and sports, a fellow of the American Academy of Orthopedic Manual Physical Therapists, quite the
100%.
credentials, also residency faculty and co-director of clinical research at Stanford Healthcare.
It's great to be here.
And you've literally written book chapters on functional testing, published tons on related topics. So yeah, we're ready to dive deep.
Thanks. Yeah, the mission here, and it really mirrors the course's goal, is to take that subjective process, that guessing, and replace it with something objective, something evidence-based. You think about it, knee rehab, hip rehab, they often have pretty clear protocols, right?
More established pathways.
Exactly. But foot and ankle, it's lagged behind. So the aim is to give you, the listener, a systematic, comprehensive framework. It uses validated tests, performance tests, and integrates them with patient-reported outcomes to really pin down readiness.
Okay, so why? Why has the foot and ankle been such a sticking point, this guessing game, compared to the knee, for instance? And what are the sort of foundational ideas this course puts forward?
Yeah, it's a great question. What's fascinating, and maybe a bit counterintuitive, is that we're drowning in data in sports medicine today.
Mm-hmm. Tons of it.
But that doesn't mean it's all useful data. We have to be really selective. What do we measure? And just as importantly, how do we measure it? And the course tackles this head-on, the core idea. Not all tests and measures are created equal. Simple, but profound. So that leads to the next question for you listening. What actually makes a measurement meaningful? Whether you're the clinician or the person checking your own readiness. The course material highlights 5 absolutely critical components. You need to know these. First up, reliability.
Okay, reliability, meaning?
Meaning, is the test consistent? If you do it today, then tomorrow, do you get roughly the same result? If a different clinician does it, is it consistent for that same person? Like a good bathroom scale, basically.
Right, consistency. Got it. What's number 2?
Number 2, validity. This is huge. Does the test actually measure what you think it's measuring? And how well does that measurement stack up against a gold standard if one exists?
So is it accurate? Is it measuring the right target?
Precisely.
Yeah.
Then number 3, standard error of measure, or SAVZM. This one's often missed. It tells you about the inherent noise in any measurement.
Noise, like just random fluctuation.
Exactly. So you know if a change you see, maybe a 5-degree improvement in motion, is a real change, or just within that margin of error, it helps you avoid chasing ghosts.
Ah, I see. That's super important for tracking progress.
Absolutely. Which leads directly to number 4, minimal detectable change, or MDC. What's the smallest change that you can confidently say is real beyond that measurement noise? What's truly meaningful progress?
Okay, so SCM is the noise, MDC is the smallest real step above the noise.
You got it. And finally, number 5, normative data. How do you interpret the results? What's normal or expected for someone's age, gender, activity level, maybe even their specific condition? Context is everything.
Right. A score doesn't mean much in isolation.
Not at all. So the course gives you this powerful filtering process. 5 key questions to ask about any test you're considering using. 1, do you know its physical quality? 2, its outcome measures. 3, does it have solid validity and reliability data behind it? 4, do you actually know how to perform it correctly and interpret the results?
Okay.
And 5, can you use it to do at least 2 of these 3 things: monitor progress, prescribe interventions, or rank performance? If you're hitting no on most of those.
Then you probably shouldn't be using it, or you need to learn more.
Exactly. You need to educate yourself or find a better tool.
So the big picture here for the listener is really about empowerment, isn't it? It's teaching you how to critically evaluate your assessment tools, not just follow a recipe blindly, moving from guessing to, well, knowing.
That's the fundamental shift we're aiming for.
Okay, we've got those core principles down. Let's dive into the first specific area. Range of motion, or ROM. Seems basic, right? But what are the common mistakes, and what are some really unique insights the course offers here?
Yeah, ROM seems straightforward, but there are definitely pitfalls. The course emphasizes consistent pro tips, Things like proper patient positioning, how you hold the goniometer, making sure you isolate the specific joint you want to measure.
Little details that make a big difference.
Huge difference, and accounting for patient comfort, obviously. Here's a key limitation to grasp, though. Using a standard goniometer often underestimates true big-toe dorsiflexion, that upward bend, compared to what you'd see on an X-ray.
Oh, interesting. So the clinical measurement might look low, but it could still be functionally okay.
Potentially, yes.
Uh-huh.
You need to understand that limitation. But here's maybe the first really big aha moment from the course regarding ROM and the foot.
Okay, lay it on us.
Your patient's static foot posture, how their arch looks just standing there. Even using tools like the Foot Posture Index, it explains only a tiny amount, like maybe up to 22%, of how their foot actually moves when they're walking, running, jumping.
Wow, only 22%. That seems really low.
It is. The massive takeaway, you absolutely cannot accurately predict dynamic foot function just by looking at static posture. You have to assess movement dynamically. Static observation alone, insufficient.
That definitely challenges some common practices. What's another key ROM insight?
Another crucial one is about assessing ankle dorsiflexion, that shin forward movement. The course clearly shows how the position of the subtalar joint, the joint right below the main ankle joint, how its position dramatically affects the true ankle dorsiflexion you measure. For instance, doing a weight-bearing lunge test, if you provide some medial arch support or cue them into a more supinated subtalar position,
Like lifting the arch slightly.
right, it helps ensure the movement you're measuring is actually coming from the hindfoot, the tibialar joint, and they aren't just compensating by collapsing through their midfoot arch.
Ah, so you isolate the target joint better.
Exactly. And that has direct implications, not just for getting an accurate measurement, but also for designing effective stretches. Are you stretching the ankle or just letting the arch collapse?
That makes perfect sense. So it's about precision in both assessment and treatment.
Precisely. And beyond those, the course gets really specific on other critical ROMs, like hallux extension, that big toe bend again.
Mhm.
You need about 70 degrees for normal function. Less than that. It's a risk factor for things like bunions or even balance problems.
70 degrees, okay.
Then there's first ray mobility, the bone behind the big toe. Needs about 5 millimeters of up and down motion. Crucial for the arch, for push-off.
Mhm.
And then there's the ATRA, the Achilles tendon resting angle. This is fascinating. It's basically a non-invasive way to estimate Achilles tendon stiffness or elongation.
How does that work?
Well, they have normative values for uninjured tendons, ruptured ones, surgically repaired ones. But the really striking insight is that just a 12-degree increase in that resting dorsiflexion angle after an injury
Yeah.
can indicate the tendon has actually elongated by over a centimeter.
Wow. Just from the resting angle.
Yes. And think about the functional impact of a longer, potentially slacker Achilles tendon. It affects heel height, push-off strength, running, jumping mechanics, everything.
So this whole section really pushes you beyond just asking, does it move? It forces you to ask, how does it move? Where is the motion really coming from? And does that pattern match what's needed functionally?
That's the goal. That depth leads to much smarter clinical decisions.
Okay, let's shift gears now. Moving from ROM to balance and postural control. Obviously super important for ankle stability and injury risk. What's a key finding here that might surprise people?
Well, what's interesting is the strong consensus in the research. Postural sway, how much someone wobbles when trying to stand still, definitely correlates with ankle injury risk.
Okay, more sway, more risk. That seems intuitive.
It does. Something like 86% of the studies reviewed showed this link, especially clear in groups like high school basketball players. But here's the complication, the question it raises.
What's that?
A history of ankle sprains can itself mess with postural stability. So, is the sway predicting a new injury, or is it just a lingering effect of an old injury? It's a confounding factor you have to consider.
The chicken or the egg problem.
Sort of, yeah. So to deal with that complexity, the course introduces a really elegant framework based on dynamic systems theory. It breaks down postural control into 3 interacting parts. There's the individual, their motor system, sensory input, even cognitive function. Then there's the postural task itself. Is it just standing still,
Right.
reacting to a push, anticipating a movement?
Okay, individual task.
And the environment. Are they on a stable surface or foam? Eyes open or closed? Are they doing a simple task or something mentally demanding at the same time?
Right, like counting backwards while balancing.
Exactly. So this framework highlights that postural sway isn't just one thing. It's a conglomerate construct, as the course calls it. It's influenced by multiple potential rate limiters, weaknesses beyond just obvious muscle weakness. It could be poor sensory input, slow processing speed.
So it helps you pinpoint why someone is unstable, not just that they are unstable.
Precisely. And then the course provides this fantastic 5-level progressive assessment system for postural control. It goes from easier conditions to harder ones,
Yeah.
and it categorizes the different assessment tools you might use based on their scientific rigor. You've got the gold standard lab stuff, motion capture, fancy force plates.
Which most clinics don't have.
Right, but then it details good options like simpler force plates or even mobile apps using your phone's gyroscope, things like My Jump Lab or Sway Medical. These give you actual sway numbers.
Okay, more accessible tools.
Definitely. Then acceptable, like the BAS test, but ideally supplemented with sway metrics. And sufficient tools like the modified CTA sieve, the Y-balance test, YBTLE, maybe the reactive Y-balance, four-square hop test, often needing to cluster a few tests together.
So a whole toolbox graded by rigor.
Yes, and crucially, for each level and many of these tests, it provides specific metrics and suggested cutoff scores.
Yeah.
For example, using a force plate for single leg stance, maybe comparing total sway excursion with eyes open versus eyes closed, looking for less than a 50% increase.
Specific targets.
Or for that reactive Y balance test, aiming for accuracy over 80% and a reaction time under 785 milliseconds. This structured approach lets you systematically find the deficits and track progress really objectively.
So the big takeaway for you, the listener, is that you get this structured, science-backed way to assess balance. You can understand the why behind instability and progress people effectively, even if you don't have a high-tech lab. Your phone might be enough to get started.
That's the power of it. Practical, evidence-based guidance.
All right, let's tackle our final big domain, muscle performance, another broad area. What are the key distinctions the course makes here, and what are some maybe overlooked aspects it brings to light?
Yeah, muscle performance covers a lot. Coordination, endurance, strength, power, even reactive strength. They're all distinct, and you need different ways to assess them. The course is rigorous about the hierarchy of testing tools here, too. Gold standard, isokinetic dynamometry, the big computerized machines.
Right.
Good options include force plates, especially for measuring calf push-off force, or fixated handheld dynamometers if they give you a time force curve. Acceptable is a saucerated dynamometer without that curve.
Okay.
Sufficient includes practical field tests, maybe a 1-rep max, multi-rep testing, the classic single-leg calf raise endurance test, or even a manually fixated dynamometer, though that has limitations.
And what's considered insufficient?
For making critical return-to-sport decisions, standard manual muscle testing, the 0 to 5 scale, is deemed insufficient. It just doesn't have the sensitivity needed for high-level function.
Good to know. Now, what's a really unique insight about muscle performance, especially for the foot, that the course highlights?
Okay, here's a fascinating one. We all know the calf muscles, the plantar flexors, are crucial for pushing off, right? Propulsion.
Absolutely, powerhouse muscles.
But the course emphasizes something equally important.
Hmm.
The ability of the foot structures themselves, the arch, the ligaments, the small muscles, to resist deformation under tension, to act like a stiff lever.
Resisting deformation, meaning not collapsing.
Exactly. This stiffness is critical for efficiently transferring power from the leg through the foot and into the ground during sprinting, cutting, jumping. The old rigid foot model we sometimes use actually overestimates how much power comes from the ankle and underestimates the power generated or managed by the foot itself.
Wow, so the foot isn't just a passive link, it's an active contributor to power transfer.
A vital contributor. And this means training the foot's intrinsic muscles. Its ability to maintain that stiff arch under load is just as important as hammering away at calf raises.
That really changes the focus. How do you assess that foot capacity?
Well, the course suggests the modified spring ankle test. It's that navicular drop test, but done dynamically through sit-to-stand, squat, and calf raise phases as a simple field test for foot motor coordination under load. And for endurance, there's the midfoot endurance battery. It involves holding specific single-leg positions, like maximum heel rise with the knees straight, for 60 seconds with body weight. For higher-level athletes, maybe even adding 20% body weight. It really targets the work capacity of those foot intrinsics.
That sounds tough. So assessing the foot's own strength and endurance, not just the calf's. What's another key insight on muscle performance?
Another unique focus is looking at the shape of the strength curve through the entire range of motion, not just the single peak torque number you might get from an isokinetic test.
The shape of the curve. How so?
The course shows, for example, how someone with Achilles tendinopathy might have relatively normal peak strength, but shows specific weakness in the mid-range, or especially the end range of plantar flexion, that final push-off position.
Ah, so the peak number hides a functionally critical deficit.
Precisely. A standard peak torque measurement might completely miss it. So you learn to look at these force position graphs qualitatively. Are there dips, flat spots, weird shapes in the curve that indicate a problem?
That's a much more sophisticated way to analyze strength.
It is. And related to the Achilles, the course highlights the significant long-term deficits people can have after a rupture. Even years down the line, studies showed decreased muscle volume in the calf, shorter muscle fibers, and substantial strength deficits like nearly 50% weaker isometric plantar flexion 3 to 5 years post-injury.
50% weaker years later. That's staggering.
It really underscores the need for rigorous, ongoing assessment and rehab, not just stopping after 6 or 12 months. The deficits can linger.
Definitely. Okay, one more insight here, maybe linking it all together.
Absolutely. Connecting it to the bigger picture, the course really emphasizes the crucial role of the entire kinetic chain. This is often overlooked for ankle problems.
Meaning the hip and knee.
Exactly. Research clearly shows that decreased hip extension strength and hip abduction strength are independent risk factors for winding up with lateral ankle sprains.
Wow, weakness up at the hip increases risk down at the ankle.
Yes, and people with chronic ankle instability, or CAI, they frequently show weakness not just around the ankle, but also in their hip flexors, abductors, and external rotators.
So the problem isn't always just local to the ankle.
Often it isn't. Furthermore, weakness in the quads or hamstrings can mess up overall lower limb stability, leading to compensatory movements that put extra stress back on the ankle.
So the takeaway for listeners here is you gain this really nuanced understanding. You learn to assess not just isolated ankle or calf strength, but how the whole system, from the foot intrinsics right up to the hip, functions dynamically together.
And that leads to much more targeted, comprehensive, and ultimately more effective treatments. You stop chasing symptoms and start addressing root causes.
This has been incredibly illuminating, a really deep dive into this foot and ankle return to sport testing algorithm. We've covered the creator's background, the core principles of good testing, and uncovered some really unique, valuable insights in ROM, balance, and muscle performance. For you listening, it seems clear this course is designed to just eliminate that guesswork. It's not just what tests to do, but why they matter, how to do them rigorously and critically, how to interpret the results to make informed decisions, whether that's clinical decisions or even assessing your own readiness.
Right. It provides those specific evidence-based criteria, those cutoffs, and practical recommendations you can literally start using tomorrow.
It feels like it really elevates practice.
That's the goal. Connecting it back to that bigger picture. It's about shifting your approach towards being criterion-based, using an algorithm, having a system. Which maybe raises a final question for you to think about. How will applying these principles, understanding these nuances we've talked about, how will that elevate your ability to ensure a return to sport that's not just fast, but optimal, safe, and truly high performance? How will it help you stop the guessing game for good?
A powerful question to end on. It really highlights the potential transformation here. Don't miss the chance to explore this further if foot and ankle rehab is part of your world. We've truly only scratched the surface of the depth offered in this course material. The value seems immense.